Hi everyone, welcome to the 4D show. I am Dr. Prashant Arun, consultant physician and diabetologist at MB Hospital for Diabetes, Chennai. So, like all of you know, that Delhi is the capital of India, but India is the capital of diabetes. And the reason being, in India, most of them like carbohydrates. And definitely the Indian people, the gut also needs carbohydrates. Because unlike the Americans or the Western people, see, when we compare the Western people and the Indians, when we see Indians are sarcopenic individuals, that is, they have a lot of fat and their muscle mass is low. But when you compare the Americans or the Westerns people, they have more of muscle mass and they have less of fat because their diet mostly comprises of protein and all fibers and they have much of healthy fats. But our diet definitely has carbohydrates. But definitely, restricting carbohydrate is not a good idea. Portion control with calorie counting definitely helps, but that is mainly for the weight loss. But all this, the health, the weight, the central obesity, all that leads to metabolic diseases, and which is one of the reasons why India stands as the capital for diabetes. So today we have with us Dr. Karthik, who is from Diafine from Karthik Hospital, Bangalore. And on to you, sir.
Thank you, Prashant, for the introduction and the uh, on the whole topic, and me also. And now, Pratik, we would like to go on to the slides. So, as the introduction given by Dr. Prashant, India is definitely has overtaken or overtaking China in becoming the capital of the world in terms of diabetes. Because with development comes also other diseases which were not very common to India earlier. Earlier, it was all communicable diseases. Now it's more of non-communicable diseases that we see in the urban setup. Now, the question asked is, why is India the world capital of diabetes? So there are various reasons for that. And as you know, uh, one of the reasons what we know now is 1 in 11 adults living in India is known to be a diabetic. And more alarming is lot many people do not know that they have the disease because they feel okay because most of them could be asymptomatic. Diabetes does not mean people need to have any symptoms. And the number of people with diabetes in India is the second highest in the world compared to first being, of course, China. But I'm not surprised if we overtake it anytime soon. So 40 million of the adults in India have impaired glucose tolerance, which places them at a high risk of developing type 2 diabetes. So this impaired glucose itself is a risk factor of developing many diseases, like including cardiovascular diseases. And the rise in the number of people with type 2 diabetes is driven by a complex interplay of socioeconomic reasons, demographic, environmental, and also genetic factors which play by and large a very important role in diabetes. Now, in India, when you see the roughly, I would say the prevalence of diabetes is something between 7 to 10%. This is more of a urban setup, and there also we see that in North India, in Punjab and Chandigarh, the population of people having diabetes is much more compared to other states. In Punjab itself is around 10%, Chandigarh is about close to 13%, and down south Tamil Nadu is also trying to catch up with them with 10%. Now, in the Indian Council, the ICMR with India Diabetes Study, the largest nationally representative epidemiological survey conducted in India on diabetes and pre-diabetes, the data it's collected over 15 states and union territories, and the study showed that the prevalence of diabetes ranged from 3.5 to 8.7%. This included even the rural setup. And when it comes to urban area, it was somewhere between 6 and 15%. And the prevalence varied from 4.3% in Bihar to 13.6% in Niger. See, Bihar, I have my doubts because I don't think the healthcare setup is very robust in Bihar. So probably the testing wouldn't have been as much as when you compare to Chandigarh or other states that are much more developed. Now, what are the risk factors for diabetes? Now, one could be family history, which is one of the major risk factors, being overweight, unhealthy diet, physical inactivity, Age, of course, once people age, we tend to get a lot of diseases because of aging, high blood pressure, and even ethnicity. When it comes to ethnicity, as Dr. Prashant mentioned, we Indians are much more prone to develop these kinds of metabolic uh, diseases, and that especially when it comes to diabetes, we have a tendency to have increased insulin resistance. And when you see an Indian male or female, the phenotype is such that they have much more abdominal adiposity. So uh, they could appear overweight, but then if you see, much of the weight is around their waist. And that's also something to do with the thrifty gene hypothesis, where there's a lot of starvation, inadequate food, and that led to a large storage of adiposity in the abdominal area. They also have lower adiponectin, higher level of C-reactive proteins, and this phenotype makes Asian Indians more prone to diabetes and also other metabolic diseases, including premature coronary artery disease, which we see very common in our practice, where people who are much younger tend to have MIs. And lack of exercise. Because of our daily schedule, our urbanization, and hectic lifestyle, we tend not to devote time to physical activity. Even we doctors who are busy also we neglect in that aspect, and I'm sure in the urban setup it's very common. And lack of exercise is a major contributing factor in developing metabolic disease, including diabetes. Because when there's exercise, there are certain receptors that open up and enables glucose to get into the cells, and also it decreases insulin resistance. So thereby contributing in better glycemic control or even prevention of diabetes. So when there's lack of exercise, the opposite happens, where there is increased insulin resistance and a lot of blood sugar remains outside the cells, and that leads to diabetes. And also, what we have seen in the survey is 30% of Indians aged between 18 to 47 years do not have any form of physical activity. And this age group of 18 to 47 is the productive age of any person and of the country as well. As expected in the rural areas, the prevalence is less because there is some amount of physical activity or even walking. People use less of four wheelers or two wheelers in rural areas, and there's a lot of agriculture activity and involvement in that. Now, sedentary lifestyle is very common because of the profession. So we tend to sit at the desk for longer periods of time, be it a doctor or computer engineer or whatever field. And the urbanization has led to sedentary lifestyle. When we compare urbanization today, it's around 35% when compared to 1950s, where it was only 8%. And studies have proved that socio-economic development over the past 4 decades has brought tremendous change in our lifestyle, leading to reduction in physical activity due to technological advancement. Because now we don't even go outside to get anything; we just order it over Swiggy or even apps to deliver vegetables home, and we even don't do the shopping as we used to do earlier. And this leads to obesity and is much more uh, rampant as expected. And that is one of the reasons why we see more of impaired glucose tolerance and diabetes among young Indian population, especially in the urban setup. Obesity is known to be a major risk factor for diabetes because it promotes insulin resistance. And however, when we compare India to the West, the obesity is not as alarming as the West, but still we see that people do become diabetic at a lower BMI. So this says that we as Indians, we are genetically predisposed to developing diabetes at a lower BMI. And these determinants make Indians more prone to develop complications much earlier in their formative years or even in the productive years of 20 to 40 years. So once people have complications, then they need to spend more time running around hospitals and getting treated, and that reduces their productivity and also income, and that translates into lower GDP of the country as well. Now, this was one study around which this tried to find out what is the prevalence of obesity among the population, men and women. It was seen that more women were seen to be obese than men. That is around in the age group of 20 to 30, we saw that 65% were overweight and 62% felt obesity impacted even their sexual performance. So across all age groups, when you see 80% were overweight and obesity was over 82% higher in women when compared to men, it was only 76%. And medical complications due to overweight and obesity was the main concern, but only around 19% of the respondents knew that obesity could trigger diabetes. Now, this is a very sad thing because people in India, because of the past where people used to be malnourished, and that translated into their socioeconomic status, and when they had an idea where when a person is well nourished, is well to do, and is from a better socioeconomic status than a person who is malnourished. Now that continues to be in our psychology, and we always, we when we speak, we always make comments that somebody is well-to-do if is on the fatter side, obese. That also happens among our Indian women who tend to overfeed their kids and want them to be looking good or more fat, which they think is better off. But actually, it is the opposite effect. Now, what are the ways we could reduce diabetes among Indians and prevent overtaking China and becoming the capital of diabetes in India? Rather, we should actually be the diabetic care capital rather than being the diabetic capital of the world. So, we should focus on diet and regular exercises. We should emphasize that in our patients and also in the youngsters. We should regularly check our blood sugar levels, be more adherent in taking medications, have an eye on the cholesterol because even that is important in terms of cardiovascular disease. We should take care of the kidneys because that's one of the issues. Chronic kidney disease is one of the issues with long-standing diabetes. And weight loss is a must, and nearly 5 to 7% of weight loss is something we should promote in all our patients and the population as well, and good oral hygiene. Now, the Indian diet is more, as Dr. Prashant said, is more of carbohydrates. Now, we need to see even in the carbohydrate diet, what we call as low glycemic index diet should be promoted, like whole wheat, brown rice, oats, etc. And that should replace the high glycemic food like white rice and other food. Now, we should avoid refined cereal products like white bread, noodles, white rice, basically the fast food we should avoid. And exercise is something that is overlooked and something that is very difficult to get people to do because they feel that taking a pill is much easier than lifestyle modification. But we should at least ask our patients and the population to have some form of physical activity at least 150 minutes a week. So at least half an hour a day is at least what they should do. And it is important to get our HbA1c test done regularly, at least twice a year, because it's an expensive test, if not earlier. And that gives us a direction as to where we are with our patients, because if a patient comes with just blood sugar levels, it could be a reflection of that particular day or the previous day. But an HbA1c gives us a better reflection of the overall control and in what direction we are actually going in achieving better glycemic control. Now, adhering to medication is something that's very important because people feel that taking pills is more harmful. They feel that taking the English medicine, allopathic medication, causes kidney disease or causes more harm to their body. So that's a myth that we should need to talk to patients and people and put to rest and say that having better diabetic control is actually should be their goal. And missing medication can increase the risk of the suffering from several diabetes related health complications. Now, there are a lot of improvements in ways of therapies in diabetes. We have moved away from the older therapies, and there are a lot of things that we can offer to our patients today. There are drugs like DPP4 inhibitors, SGLT2 inhibitors, GLP-1 receptor agonists, which work wonderfully in controlling their blood sugar and also reducing weight. And it's we have moved away from focusing on the glucocentric approach to our patients than and now we more focus on the core morbidities, and then we incorporate the medications. And early initiation and early treatment is very important. We should not wait for the blood sugars to go up and the HbA1c to climb high and then try to add um, another drug. We should even consider dual therapy, one or two medications or more initially, depending on the blood sugar values and the comorbidities. So there are fixed dose combinations now, and SGLT2, most of them are off patent and widely available, much affordable now. And we have SGLT2 with DPP4 inhibitors, and in a suitable option for our Indian diabetic patients. And because they are safer, rapid, and they give sustained glycemic control, it improves both insulin resistance and beta cell function. It helps reduce body weight and blood pressure. SGLT2 is known to reduce weight by nearly 3 to 4 kilos and also reduces the systolic and diastolic blood pressure. And it reduces the pill burden, and the overall cost is also minimal. So, some of the guidelines for combination to manage blood glucose levels are to stabilize. It should be initiated at least 2 weeks to 1 month before fasting. So this is something I think to do with fasting and Ramadan. So I wouldn't want to touch much upon that. But yeah, they are much very safe to use SGLT2 and DPP4 inhibitors, and we could use the fixed dose combination to the benefits of our patients. I think with that I hand over the session to Dr. Prashant.
Thank you. Thank you so much, Dr. Karthik. So, actually, that was a wonderful presentation. And the best point I liked there is what you said about we becoming the diabetes care capital. That was a very nice line used because we are now the diabetes capital and we becoming the diabetes care capital. Definitely, yes. We would just like to take some questions because we've got some audience listening and then we've got some questions. So just could you throw some light on IGT, that is the for the pre-diabetes, or what is pre-diabetes? Can you throw some light on pre-diabetes IGT?
So we diagnose diabetes in terms of HbA1c, which is a test that confirms if a patient is diabetic or not. So we say whoever has an HbA1c of more than 6.5 with the corresponding high blood sugars, maybe fasting or postprandial, we say that they are diabetic. So pre-diabetes levels would be between 5.7 to 6.4. So anybody who falls in a pre-diabetes range, we call them pre-diabetes. So this is the stage where a person will be developing insulin resistance. But still, his pancreas is producing enough insulin or trying to overcome the insulin resistance, so that they will probably have hyper insulin secretion. And this is a stage where intervention can help them to reverse diabetics. So, what we say today, there are a lot of talk about reversal of diabetes, but there's actually remission of diabetes. That's another topic which for we can keep it for another day. But then, actually, if you intervene in this period of in this phase of impaired glucose tolerance, that is a phase where really you could, to some extent, reverse diabetes. When you, if you put in the correct diet, the advice, and the physical activity, reduction of weight, then the insulin resistance drops, and their pancreas is able to sufficiently produce enough insulin to keep the blood sugars under control, and then it prevents also from the progression of failure of the beta cells.
Beta cell.
Thereby, this is a very crucial phase, and people should be tested more often. And if they find they are in this stage of impaired glucose tolerance, they should seek medicine and treat it very aggressively. That's what my take would be. Rather than say that, I'm still pre-diabetic or I'm impaired glucose tolerance, I don't need to get treated, I don't need to take pills, I don't need any modification, let me wait till I become a diabetic. That should not be the approach.
Sure. What is this insulin resistance? Because many people might not know what this insulin resistance is and how to overcome this insulin resistance. How do we treat this insulin resistance?
See, primarily insulin resistance is the major contributing factor for insulin resistance is obesity. So, because a patient is obese, the BMI is high, and the level of blood sugars that due to either overconsumption or obesity itself, the insulin secreted to the body is not able to overcome the necessity to keep the blood sugars under control. So thereby, there's hyperinsulin secretion, but still the insulin does not act adequately, and this leads to insulin resistance. There are various secondary factors, but I wouldn't want to go into that. But primarily, it would be obesity, which is the major contributing factor for insulin resistance.
Okay.
Thereby, if you
Okay,
want
one
to
of
reduce insulin resistance, thereby you should reduce weight and try to achieve your BMI at least less than 23 for Indians to reduce insulin resistance.
So one of your slides that showed that the incidence of diabetes is more in the urban population when compared to the rural population. What could the reason be that the urban population, the incidence of diabetes is more compared to the rural population? Because even I've had many patients who come where the patients in the rural areas are actually well under control or they don't have diabetes. But when you compare to the urban, could it be the lifestyle or could it be their diet or what could be the reason because behind this?
Definitely, it is the lifestyle and the probably even the profession. What the difference between profession between the rural and the urban? See, in urban, most of the professions are either software engineers or any other office goers who spend their time sitting at a desk and fulfilling their professional obligations. Whereas the rural side, it will be more of agriculture or more of something to do where they need to put in their physical activities like walking or cycling or something like that. And even the food habits change when it comes to urban and rural population. Now, I've seen rural population where they just have 2 meals a day, the one at 11 o'clock and the other one at 6 o'clock. There's something like intermittent fasting. So, and they don't take any, and their food also is, even though it's rich in carbohydrate, it's not it doesn't have the other aspects of added sugar in them. So like the fast foods we eat. So some aspect the lifestyle in that way does contribute to this disparity between the urban and the rural prevalence of diabetes. But what I have seen now is the rural population slowly catching up with the urban population in terms of diabetes, and that it's becoming a very thin line. And for a few years from now, I don't think we will be differentiating between the rural and the urban population because the rural area is becoming rapidly urbanized.
No.
And definitely, as you said, it is because of the lifestyle and inadequate physical activity and the food habits that contribute to this issue.
Sure. And as you were saying that in the urban population, we have people of more of engineers and people. But this COVID era, the last years when we had the COVID, most of them were in lockdown. And even now, I think most of them are in one work from home basis. So post COVID era, do you feel that the diabetes or the incidence of diabetes has increased or the gen that is the age group of diabetes has actually come down and that the younger generation is developing more of diabetes because most of them have lost their physical activity because initially they used to at least travel from home to work but now that's also gone. They just sit where they are, work from home, they sit and count. So that is also a loss. Do you feel that this has changed anything post COVID era? Is there a change in the incidence of diabetes?
See, in my practice, I have not seen a change in the incidence of diabetes post COVID. I think it's the same. But during COVID, I could see that some people were more health conscious. They spent more time on their health and weight reduction. They had time to focus on their health. This is among the normal population who are probably with pre-diabetes or recently diagnosed diabetes, or even people without diabetes. But people with diabetes, I think they face some challenges. Some people could not get the test done, or they avoided getting their regular test done, or even going for the regular follow-ups with the doctors. And they tend to come with higher HbA1cs and poor control. So there's a mixed bag of in what I saw.
Okay. What would be your opinion about SGLT2 inhibitors for an age group more than 75? Because we know that the SGLT2 inhibitors are really good. It protects from diabetic complications, it helps prevent kidney disease, it prevents for the heart failure. But how could we use this SGLT2 inhibitors for people over the age of 75?
See, there was a lot of reluctance initially to use SGLT2 inhibitors in the older age group, especially more than 60, 65 also initially. But then later on, the guidelines came that you could use it in a much older population. But the only thing is we should use it with little precaution. Now, one, we should make sure that the patient is not insulopenic already to prevent some form of DKA, which can be seen in a few patients. And also, we should see what are the other comorbidities, because patients with cardiovascular disease like heart failure, they benefit much better with SGLT2 inhibitors. So they would be ideal candidate, and even age should not prevent us from offering them this molecule. And also, what some patients I've seen is hypovolemia, and that should be taken care of because old people may have, due to their diet or inadequate fluid intake, that could be an issue. And even that could be addressed by informing them adequately. But I would not prevent or not offer a older uh, diabetic person, an SGLT2 inhibitor. I would want to put them on SGLT2 inhibitor with caution because the benefits outweigh the risks.
Okay. What are, can you throw some light on the complications of diabetes? That is, diabetes is just not numbers that is controlling the numbers, because we are trying here to prevent the complications of diabetes. Can you just tell the audience about the complications of diabetes? What are the complications due to diabetes and how to prevent the complications? Because SGLT2 inhibitors are going to help reduce weight, it's going to help us reduce the complications, but what are the complications of diabetes?
Yeah, see, now what, see, when somebody asks me what is diabetes and what is treatment of diabetes, I would say you don't treat diabetes because you want to control sugars. You treat diabetes to prevent the complications. So our
Well
ultimate
said.
aim is just prevent the complications. That's why we treat diabetes. Otherwise, there's no necessary for us to, target
It's
the
not
sugar.
bringing down the numbers.
Yeah, so it doesn't matter. So if somebody were to have 400, 500 sugars and they were able to be asymptomatic and it had no complications, I'm sure we would not be treating diabetes at all. So we are treating diabetes just because it's known to cause complications. And there were several studies like the UKPD studies and several other large studies which has shown that above a certain HbA1c, people tend to develop certain complications. Like, for example, retinopathy, which is very much preventable. So retinopathy is something if you don't prevent, a person can lose their eyesight. And also coronary artery disease, premature coronary artery disease. That's what we see in uncontrolled diabetes. So that's another factor where that is also preventable by adequately controlling HbA1c. Even though there are very few studies showing that uh, tight glycemic control leads to better microvascular complications, but still there is some data showing that yes, there is benefits with tight glycemic control. And also achieving an HbA1c much lower, like say 6.5, early in the diabetes goes a long way in preventing hypoglycemic episodes later. Because if you let a diabetic patient to be used to a HbA1c of 7 above or 8, when you try to lower the blood sugar in them, get the HbA1c to 6.5, they tend to face a lot of episodes of hypoglycemia. But if you keep the HbA1c much lower initially itself, so the body is adequately accustomed to the blood sugar levels and they tend to have much lesser hypoglycemic events. Or their body is much better to cope with the hypoglycemia. And also coming to another microvascular complications like kidney disease. So nearly 30 to 40% of the diabetic population, uncontrolled diabetic population, tend to have some form of CKD, and most of them die due to macrovascular complications like heart attacks, or some of them end up with chronic kidney disease. So even chronic kidney disease can be prevented or at least delayed in diabetic population, because if somebody develops a chronic kidney disease at a young age of 40, 50, so he's going to spend rest of his life going to, if he happens to have end stage renal disease, then at least he has to go twice a week for renal replacement therapy, and that's going to drain on his finances. It's going to prevent his productivity in terms of economic sense earning, and not only that, he needs another person to accompany him for the dialysis, and then even that person has to take off something. So there's a lot of burden on the family as a whole. So it's very important to prevent these kinds of complications, because it's not only the health aspect, but also the economic and the social aspect that we should take into consideration. Also, other complications of peripheral vascular disease. So that's also a contributing factor. And if a diabetic foot, what we say that if a person develops any cellulitis or any infection, there is an issue, and even the productivity goes down. They have to nearly be on bed rest or frequenting their doctors for a long time. So all these complications can be prevented. One is peripheral neuropathy that also contributes to neuropathic ulcers. So keeping your HbA1c levels uh, adequately, like say 6.5 to 7%, very much early in the disease, at least delays your complications to until you're old. So that's what we want to see. We want if a person who's in their 70s or 80s has some form of complications, yes, their lifespan is also less, and the amount of time they deal with the complications is less. But we don't want a person in their 30s or 40s to develop complications because they are going to live to at least 20, 30 years, and we don't want them to face the complications for that long.
Sure. Talking about diabetic kidney disease or chronic kidney disease, because most of the patient when they come to the OP for checkup, they just come for doing a HbA1c fasting postprandial. Maybe they do a creatinine, but more than that, when we tell them to do look for albumin, they don't just say, because they say I have just come here for my sugar, and basically people with diabetes are more have cholesterol, they have dyslipidemia, they have albuminuria, they have BP. So we'll have to put them on some ACE or ARB to reduce their albuminuria, in turn to protect the kidney. What is your say on this?
See, that is one test that most of the family physicians do not get it done, and we miss out on that. So when a patient walks in, I think along with the other basic tests like his blood sugars, HbA1c, fasting, postprandial, his serum creatinine, serum electrolytes, he should get an UACR, that is urine albumin creatinine ratio, done. And if there is microalbuminuria, it's very easily preventable by like medications, what you suggested, ACE inhibitors or ARBs. There are other medications that have come recently, so that all prevents albuminuria, and this goes a long way in preventing chronic kidney disease much earlier. So it is important to monitor this aspect and emphasize. And also, when you get an UACR done, that is urine albumin creatinine ratio, make sure that you get the first urine sample in the morning, that is fasting as soon as the patient gets up, and ask him to get that to the lab and get it tested. And repeat it probably after 2 weeks or a month. And then if you find that the he has microalbuminuria, then you could treat him.
Definitely. So one is kidney. Now screening for the kidney disease, albumin. We should definitely screen the foot also for diabetes. Definitely, we'll have to look for the
Yeah.
diabetic neuropathy, whether the sensation is there in the foot, because most of them, because in the OP procedures, mostly we see sugars, we see, but most of them miss to look at the foot. Can you throw some light on that, on the foot examination for a
Just to
diabetic
add to
patient?
what I was saying earlier, so if you find a person with microalbuminuria, don't forget to check the eyes, because usually
Yes.
people who has some form of kidney disease will definitely have retinopathy, and so we always correlate. If a person has retinopathy, then he has nephropathy, and nephropathy with retinopathy says it's diabetic kidney disease, or the reasons could be something else. Okay,
To,
yes, sir.
yeah,
Coming
the
to
foot.
Yeah, foot.
Foot.
Coming to the foot. See, foot is what we say in diabetes is if you do not examine the foot, then your examination is not complete, and especially with a diabetic patient. So always never send a patient without looking at his foot. Because tinea pedis is very common among our diabetes patients, and it's usually missed because we can't see it, and you should look for it because that's the port of entry for all infections that could lead to cellulitis and various ischemic limb disease. So that is one thing, and look for neuropathic ulcers because improper footwear will lead to usually they have claw feet where there's a lot of pressure points developed. So look for pressure points and look for the sensation. A simple tuning fork can be used to see whether they have adequate sensation or not. You don't need the other complicated gadgets. So look for pulses in the feet. Look for sensation in terms of tuning fork, and also microfilament can be used to see what their level of sensations are. and see if there's any difference, and then they should be advised to use proper footwear and change the footwear every 6 months. So we should also tell your patients to take care of your feet like as you take care of your face.
Sure.
So they should look at their feet every day after a bath and see for if there's any infection. Because if a person tends to have diabetic neuropathy, probably is not going to notice any ulcers or any injury to his leg, and that the when he's going to notice it, it may be too late.
Sure. So, to move on to the last question, triple drug combination, that is now everybody is talking about the triple drug combination, that is the SGLT2 inhibitors, the DPP4 with the metformin. Individually, all of us have used all these three molecules separately. Now, just the thing is that all the three are married together now. And when would you suggest using the triple drug combination? Because usually the triple drug combination comes now. They're going to come out with the 500, but as of now, it's only the 1,000 milligrams that is available with the metformin. So, which patients would you avoid this triple drug combination, or which area would you suggest this triple drug combination? And the next part of the question is, would you like using the SGLT2 inhibitors separately, the DPP4 inhibitors separately? This is three questions asked in one.
See, see, diabetes treatment is not like one treatment suits all. So it's definitely it has to be tailor made. So each patient is different, their needs are different, and their comorbidities are different. But definitely, this triple drug therapy has a place in our daily practice because the primary point being it reduces the pill burden and also the cost to some effect. Now, if a patient is already on a metformin, which he will be by default unless it's contraindicated, then usually we add a DPP4 inhibitor. Then with an inadequate control, if he needs a SGLT2 inhibitor, we add a SGLT2 inhibitor. Now, if this particular patient is stable on all the three drugs and he has no other contraindication to either withdraw any of the drugs, then this patient is ideal for a fixed dose combination or a triple drug combination because of the reasons I just mentioned, because it reduces the pill burden and also the cost. But whereas if there is another patient where the serum creatinine or the CKD, where you need to really alter the dose, you want to withdraw the metformin, you may want to continue the SGLT2 inhibitors because even with CKD it is shown to have some benefits of preventing the progression of CKD. And also DPP4 inhibitors can be used. Certain DPP4 inhibitors like linagliptin can be used even with CKD. So in those subjects, maybe you need to give them separately, and these fixed dose combinations may not work.
Sure. I would like to thank Dr. Karthik Munichudappa for enlightening us so much about this topic because the 4D show, we have general physicians, we have PGs, we have patients, we have general audience, we have so many people listening to this. And definitely, I'm sure they would have gained some knowledge out of this session. So I would again like to thank Dr. Karthik Munichudappa for enlightening us for this session. Thank you, sir.
Thank you, Dr. Prashant. It was wonderful